Thank you very much. So I'm going to be speaking on cases in neuroradiology, both adult and pediatric, and I hope to stimulate some blood flow into your brain with the questions that we show you. So these are the objectives which the chairpersons have kindly gone through already. So this is the first case, a young girl with neurofibromatosis. So neurofibromatosis type 1, she presented with an acute left-sided deficit, and you can see on the CT scan it was because of an acute hematoma. And on the CT angiogram that we did at the same time, if you look at it carefully, you can see that in the bifurcation of the right MCA is this small saccular aneurysm. And that's the aneurysm over there on the angiogram, on the oblique right internal cerebral artery angiogram. So this is just to show you better the cause of that hemorrhage. This is the aneurysm in the bifurcation or the trifurcation of the right middle cerebral artery. And you can see it well over here. This was coiled very successfully by our interventional neuroradiologist, and it seemed that the coiling was complete and there was no residual sac left. So as a follow-up, after 6 weeks, she also underwent surgery to take out the hematoma because she was coning, so there's some surgical change over there. This was the angiogram after 6 weeks, and you could see that this is the appearance of the axial flare. This is the diffusion weighted image. This is the right MCA after the coiling, 6 weeks after coiling, and if you go back, you can see this was the appearance after coiling. And this was the CT scan, the MR with contrast done at the same time. I showed you the MR, axial flare, sagittal T1, this is the area, diffusion images, and this is with contrast. So this is the area of the coil, that little susceptibility artifact, and there was this enhancing soft tissue along the right distal middle cerebral artery. So if you look at this, then tell me on the 6-week follow-up images, what is the most likely diagnosis? Can I have a remote, please? So does everybody have a remote? Oh, so some of them don't have a remote. Who else doesn't have a remote? And make sure it is on, you'll see a 3-digit number. Okay, so one person here doesn't have a remote. Anybody else who doesn't have a remote? All right. So I'll try this and start answering now. That sound means it is on, and you can see the seconds. We have 15 seconds, so you only have 9 seconds now. Make a choice from A, B, C, D, that is 1, 2, 3, 4. Let's see the answers. So some people said actively leaking aneurysm, some people said enhancing foreign body, so obviously there was something left behind, that means lack of confidence in the neurosurgeon. And some people said 4. So very few people answered actually, only 4 people, how come? So anyway, hopefully more people will participate in the next one. So the answer was actually a tumor, and I'll show you why. If you go back and look at those images, this enhancing thing was diffusion restricted a little bit, and you can see the mass effect on the branches of the MCA. And if you look at the follow-up, this was on January 28, 2010. Are we okay? Yeah. And you can see that boom, the tumor has exploded within just a couple of months on March 31st, 2010. And this was a path-proven sarcoma, NF1. So the teaching point over here is whenever you have any phacomatoses, NF1, NF2, tuberous sclerosis, VHL, these are conditions where the tumor suppressor genes have been eradicated or they're no longer present. So all these phacomatoses have a high incidence of weird and unusual tumors. So remember that an occasional enhancing weird lesion in a setting of phacomatous, always worry about a tumor. So this was a path-proven sarcoma. I've seen 4 such cases like this now, starting off with minimal enhancement. This was more obvious enhancement. And you wonder whether the tumor caused this aneurysm secondary or was it just coincidentally present at the same time. We would never know. So this is another interesting case, and this is straightforward if you know the anatomy. And if you don't know the anatomy, once you see it now, you'll always make a diagnosis. So from the history itself, you can make a diagnosis, but I wanted to show you the imaging appearances. That's why I'm withholding the history over here. So recently immigrated 1-year-old girl. Now, if you look at these images, these are sagittal oblique T2 images. This is on the right side. This is on the left side. This is a magnified view of the right side. This is a magnified view of the same left side. So if you look at the diagnosis, if you look at these sagittal oblique T2 images, and these are done through the internal auditory canals. Look at it carefully. What do you see on the right side? And what do you see or not see on the left side? And then give the most likely diagnosis. Do you want to look at those images again? Okay, let's go back. This is the right side. This is the superior semicircular canal. These are normal, but the abnormality is within the internal auditory canal. That's why I've blown it up for you. This is superior, this is anterior. And then look at the differentials. Is this cochlear nerve hypoplasia, vestibular nerve hypoplasia, facial vestibular nerve fusion, or is it facial nerve hypoplasia? So let's start. So take your remotes. You have 25% chance of being correct even if you don't know the answer. Let's start. You have 10 more seconds. A, B, C, D, 1, 2, 3, 4. All right. So everybody's distributed equally and many more people answered now, which is great. So unfortunately, the answer which is correct is number 4, and very few people got it, which is good. That means I can teach something. So this was a very rare incidence anyway, but you could pick it up if you knew the diagnosis and if you knew the history. The history was congenital facial muscle weakness on the left side, and the answer is facial nerve hypoplasia. So let me show you the anatomy. If you go back over here, this is the cochlear nerve. Sorry, this is the facial nerve, this is the cochlear nerve, this is the superior inferior vestibular nerve. And you can see that the facial nerve was missing on this side. Now usually what happens is we do this for the hearing loss. Let me go through some anatomy. So this is axial CT scan section through the IAC at the level of the cochlea. And you can see the anatomy over here, I've blown that up. This is the cochlear aperture or the cochlear bony nerve canal. This is the cochlear modulus, the basal turn of the cochlea, the modulus, the malleus and incus, which together form the ice cream cone sign, and this is the vestibule, and the vestibular aqueduct is over here. This is the vestibule. So over here in this patient, the cochlear bony nerve canal is normal, and this is a normal patient with normal anatomy. I'm showing you this ice cream cone for a reason. The ossicles together, this is more for the trainees. This is the ice cream, and this is the cone. It is known as the ice cream cone sign for normal appearance of the middle ear ossicles. This is to show you the nerves within the IAC. This is the 7th nerve nucleus within the brainstem. The motor roots goes around the 6th nerve nucleus, causes a little bump over here, the facial colliculi. You can imagine that these are baby's bums if you look at a baby's bum from behind. And this is the 7th or the cochlear nerve. Sometimes it's difficult to differentiate only on axials. And these are the 8th nerves behind. And if you look at what we do to evaluate for congenital hearing loss, we do sagittal oblique images in this plane, and you can get appearances like this. Either you see a smiley face with the 2 anterior nerves, that is the facial and cochlear, and the 2 vestibular nerves sometimes can have a tag of tissue between them, or you can get that vestibular nerves posteriorly as separate. So facial nerve, cochlear nerve, superior vestibular nerve, inferior vestibular nerve. Very easy way to remember. 7 up, the 7th nerve is up anteriorly, and the cochlear nerve is, the Coca-Cola down, is inferiorly. So that's one way of remembering it. So in that case, you could see that the facial nerve was missing and that was facial nerve hypoplasia, but we apply the same principles to hearing loss and you can pick up cochlear nerve hypoplasia. So if you look at the right sagittal oblique, the cochlear nerve is missing over here, facial nerve is present. So usually we evaluate this for cochlear nerve hypoplasia. And this is a very interesting patient. Actually her name is Snow Summer, very unusual name. It was a false name given to a VIP patient, but that's how it's listed in our PACS stations. And you cannot identify this patient even if you try to find it. So this was right cochlear nerve deficiency, just a companion case. Okay, we come to case 3. And this is a little more images over here, so we'll take our time. Sagittal T1. Make sure you look at everything, including structures in the midline, vessels, etc. This is diffusion trace image, ADC map. This is the MR angiography MIP image as if you're looking at it from the top. This is anterior, this is posterior, left and right. This is a source image through the middle, through this level, say through the mid-pons level over here. So these are the ICAs. Now if you look at this properly, we'll go on to what you think is the diagnosis. So I have 2 questions, but you need to answer only the first one. What is the diagnosis? If you want, we can go back again, look at it. The diffusion images, the angiography images, the sagittal T1 image. And this girl was otherwise normal except for diplopia. She came in walking into the MR. I still remember her name because I so vividly remember these interesting cases. So let's start. So just answer the first question. The second question I'll answer for you. So take your remotes in your hand, be ready, and you have 15 seconds. Let's see that everybody gets an answer over here. Is it a midbrain infarct? Is it basilar artery thrombosis? Is it both of them, or is it none of the above? All right. Fantastic. Most people got it correct. Excellent. So it is midbrain infarct and basilar artery thrombosis. It is all of the above. And you can see that this was the midbrain infarct on the left side. Classic sharp median cutoff of an infarct in the midbrain. Restriction on DWI. You see there was hardly any flow in the basilar artery, and you cannot see the basilar artery. The PCAs are supplied by the posterior communicating artery. And this is the basilar artery, which if you look carefully is showing abnormal signal. It should be a flow void. It should be dark. So, and how will you treat this? So obviously she was not an acute case of infarct. She wasn't so bad. She just had diplopia, was otherwise normal. And it was surprising for the extent of midbrain infarct. She had very little symptoms. So we considered further vascular imaging. So let me show that to you. So this is an injection in the left basilar artery, left vertebral artery, and you can see this thrombus, with this sort of hematoma stuck to the wall with a floating distal thrombus, which had actually some part of it had gone distally and blocked the basilar artery. So she had basilar artery thrombosis due to embolic phenomena. So teaching point over here is any posterior fossa infarct in a young adult, you look for this area of the vertebral artery that is from OC1, because vertebral artery dissections are a common source of posterior fossa infarct. So anytime you see posterior circulation infarct in a young adult, always look at the vertebral artery in the upper neck from occipital bone up to C2, because as it swings through C1, C2 to go up into the foramen magnum, that is where it gets injured or gets dissected. So this was classic evidence for a dissection. Very, very common site for dissections in the vertebral artery. So just play for it once again, and you can see this is the site. Okay. So you can see that what happened over time with follow-up is this developed a pseudo aneurysm, and this is the C1 odontoid. This is C2, and you can see the vertebral artery swings in over here and goes into the dura, right? And this is a pseudo aneurysm which has formed as a follow-up to this patient. This patient actually did very well, and I think we followed her up for 8 years till she became, she was lost to follow-up and went on to some other service. So once you have the diagnosis, then which of the following is not true for this abnormality that you just saw? So typically occurs at the C2 to dura, can evolve into stenosis or occlusion, can evolve into a pseudoaneurysm, and typically will cause subarachnoid hemorrhage. So the answer, which is not true. So let's start again. And keep your remotes ready. 15 seconds, go for it. And press OK after you've pressed the A, B, C, D. Excellent. So if you notice, most of these occur outside the dura, so they don't cause subarachnoid hemorrhage. That was perfect. And they can, this is where it typically occurs. It can become a pseudoaneurysm, it can become stenosis, it can occlude, or it could have thromboembolic symptoms. That's why you treat it with anticoagulation. Perfect. So having talked about vessel wall abnormality, yeah? So his question was high resolution T1 images for identifying dissection. Yes, you do that, but in this case I did not do it. And that's how you would evaluate. And in fact, the next topic is on that only. So since we are just post-lunch and we had a nice big lunch, I'm talking of donuts again since we are all hungry. And the reason I'm showing this to you is one of my very good friends who's a neuroradiologist at Toronto Western Hospital, actually works with Tony Hanbridge at Toronto Western. That talks about this, think of the donut, not the hole. So when you have a donut in your hand, you don't think of the hole in the middle, right? You just think of the food or the stuff that you want to eat. And this is something that is on the internet. There is a very famous Mayflower donut shop in New York. And you can Google this on the internet, and there's a nice little poem that goes with this. So this was very popular, and people used to line up to get donuts. And they used to advertise it in this way in that shop, the Optimist's Creed. As you ramble on through life, brother, whatever be your goal, keep your eye upon the donut and not upon the hole. It's very relevant, right? And why do you think I'm talking about that? Exactly the question that you asked is when we think of vascular imaging, we think of the lumen, we think of the hole, whereas what we should be thinking of is the donut, the wall of the vessel. So in fact, as we now evaluate these abnormalities, we do more vessel wall imaging than ever before, and we have started thinking in the correct way of abnormality in the vessel wall, not in the lumen. Previously, we only did angiograms and thought that was the gold standard, but that is not true. You need both techniques to look at the wall, and the effect on the lumen is secondary. So this is, if you look at this particular patient who, I'm not showing you the diffusion images, but there was a large infarct in the left MCA territory. If you follow the flow void of the MCA, you can see on the left side, I've magnified this for you, is a hyperintense clot in the wall of the vessel. This is the holy grail of arterial dissection if you see an intramural hematoma. Now we do this for dissections, whether it be in the neck or intracranially, or you can even also do it for intracranial vasculitis, particularly medium vessel vasculitis. You can see circumferential enhancement of the vessel wall, and a lot of people are also doing this for atherosclerotic disease intracranially. For example, in the carotids we do it very often, and people are also doing it for morphology of aneurysm vessel, of the aneurysmal wall. If it shows enhancement, that means it's an actively inflammatory condition which could cause the aneurysm to grow. So a lot of indications for vessel wall imaging. So think of the donut, not of the hole. So with that we come to case 4. So I want you to look at the MR images first. These are 2 T2 weighted MR images. And if you're a smart radiologist, you'll pick up the abnormality on this, because as a radiologist, you look at every structure that is visible to you. Okay, have a good look at this. Then have a look at the patient. It always helps the clinical history. This was a young patient with right-sided congenital Horner syndrome and intermittent mydriasis. This is the photograph of the patient. We have permission to show this case, and we even published this, so it's a nice case. If you want to, if you go to AJNR, you'll find this case published. So what do you notice over here? So her mydriasis was on the right side, and the Horner's was on the right side. The obvious thing was that the color of her iris is different, and that's something called as heterochromia. Okay? So give the diagnosis over here and explain the cause of the mydriasis. These are more images from the same patient, a CT to the base of the skull, MR angiography, a sagittal T1 image through the third nerve on the right side. This is the magnified portion of the same image on the right side. So once you have seen this axial CT image, sagittal T1 on the right side at the level of the third nerve, and then a time of flight MR angiography. This is the right side, this is the left side. You can go back, look at the T2 images again, look at the patient's photograph, and then let's go for what we can see. So is this congenital absence of the right ICA? Is it occlusion of the right ICA? Is it bony compression? Is there an iatrogenic cause, or is it a posterior communicating artery aneurysms? Go for the answer. After you press A, B, C, D, or even E in this case, press OK after that. Wow. Everybody got it correct, almost everybody. Fantastic. So this is a very interesting condition actually. Congenital absence of the right ICA. And I tell you that if you had clinicians from the 60s and 70s, they would not need MRA or MRI or CT to make the diagnosis, because they would make it clinically. When you have congenital absence of the ICA, the sympathetic and parasympathetic fibers which cause the color of the iris go up along that, and that was the cause of the Horner syndrome and also the heterochromia, the different colored iris. So it's also a clinical diagnosis. And if you go back, it's congenital because you can see that the left petrous bony canal was well developed. The right one is hardly developed. So this is a condition which is from very early age onwards, and the osseous bony canal is not formed. So that's why none of those acquired conditions. Now what about the posterior communicating artery aneurysm? If you look at these images, you can see that's the third nerve, and this is the second nerve, right? The optic nerve, and this is the third nerve. And there's a very prominent posterior communicating artery sitting on the third nerve. So it is acting like an aneurysm, but it's not an aneurysm, compressing the third nerve occasionally, causing intermittent mydriasis. And you can see that the third nerve, as it travels into the orbital apex, it passes between the PCA and the superior cerebellar artery. And if you had an aneurysm from the posterior communicating artery, it usually presses on the dorsomedial aspect of the third nerve, which is where the pupillary fibers run. So in this case, it wasn't an aneurysm, but it was just that the whole artery had enlarged and was pressing on the third nerve intermittently. So that was the explanation over here. Any questions on this so far? We are okay? So this is just to show you some anatomy for the trainees in the audience. On a coronal T2 image, you can see this is the superior cerebellar artery, and this is the PCA, the posterior cerebellar artery, and that's the third nerve going right through it, exactly like how I showed it to you on this diagram from StatDX or Amerisys. And this is the axial anatomy of the cistemal segment of the third nerve. Mind you, the third nerve nuclei is somewhere over here, and then the third nerve comes out over here and then goes into the apex of the orbit. This is T1 and this is T2. So with that, we come to case 5. So this is a young patient again who presents with signs and symptoms of meningitis. Axial diffusion weighted image, axial ADC map, a sagittal diffusion, and you can see this is the lesion over here, a sagittal T2, and this is a GAD sagittal T1 with fat saturated images. So this is a 3-year-old who presented with signs and symptoms of meningitis. What is the diagnosis? So is it a tumor, is it abscess, is it penetrating trauma to this 3-year-old, remember, or an epidermoid? There are some clues given on the slide. So let's see if you can answer correctly. So let's go for this. Take a remote, press A, B, C, D, and press OK after that. Once it starts, we have 15 seconds, and I want everybody to get the correct answer over here. Excellent. At least 18%, 18 of you got, 40% of you got the correct answer, which is very good. The clue on this image was, if you look at it, there was an enlarged foramen cecum. This is axial CT scan. These are the eyes over here. This is a sagittal one. And what the clinicians had missed is a small punctum at the root of the nose. And there was a dermoid sinus tract with intracranial extension going in. Now, abscess also would be a correct answer because it is diffusion restricted, but epidermoid was the answer in here. It was diffusion restricted. You know that both epidermoids and dermoids are diffusion restricted, so both answers could be correct over here. And in this particular case, the meningitic symptoms are because of rupture of this epidermoid. So when they went in to operate on this, they didn't find any infection. They just found that the epidermoid had leaked into the CSF and caused a chemical meningitis. And you can see the pearly white squamous epithelium. These are, on pathology, these are called as cell ghosts or shadow cells because you just see the wall of the cell, you don't see anything inside. And this was a classic appearance of the dermoid. So good, let's go to case number 6. And this is a young adult again with right-sided pulsatile tinnitus. This is a very interesting topic, pulsatile tinnitus and a retrotympanic vascular lesion. And this is the appearance of his right middle ear. See, this is the attachment of the handle of the malleus. And if you look closely, behind the eardrum, in the middle ear, is a reddish structure, right? I'm just giving you that clinical clue. Now, what would you do? What would you not do as a next step amongst these 5? Do I have an answer? I don't know. I didn't put the answer over here. So what would you not do? It is very obvious. Biopsy. You would not do a biopsy, perfect. And you would not do an angiogram also. But biopsy is the correct answer. You don't want to biopsy this. And look at these CT scan images on the right side. These are the right CT scan images. These are the left CT scan images. So this is the normal side. That is the abnormal side. So look at it correctly, look at it carefully, and then we have a question for you. So this is the cochlea, the petrous ICA, the petrous ICA over here. And then what is the diagnosis over here? So I put a coronal image over there, and I put an MR angiogram in the same patient as clues for you. Is this an aberrant right internal carotid artery? Is it a vascular malformation? Is it glomus tympanicum? Is it a dehiscent jugular bulb or an infected cholecystoma? What is the appearance of that retrotympanic vascular mass which was pulsatile? So let's go for the answer. Take your remotes, A, B, C, D, E, press OK after you press it, and you have 15 seconds. I'm pressing mine so I get at least one answer correct. Maybe I won't get it correct, who knows? Okay. So most of you got it correctly, which is perfect. That's what I expect. Some people need to look at it carefully. If you look at it carefully, the right ICA is aberrant as it goes around the cochlear promontory on the right side. See this petrous ICA? Whereas the petrous canal should be anteromedial to the cochlea. It shouldn't go around the cochlear promontory. Okay? And you can see that on the coronal view. This is the cochlea. This is a vascular structure, the ICA running lateral to it on the cochlear promontory. And these are the differentials for a retrotympanic pulsatile vascular mass. For example, you could have a glomus tympanicum, which also lives exactly in this location, a glomus tympanicum, but obviously doesn't continue into an elongated vessel into the ICA petrous canal. And before we had CT or MR, we used to do angiograms where we could see the lateral location of the ICA, compare that to the left side, which is normal, and that's the way we used to detect aberrant ICAs. We don't have to do an angiogram anymore. Mind you, it can so mimic a glomus tympanicum that ENT surgeons who are not used to this could insist that this is a vascular glomus tumor and want to biopsy, but you literally have to fight with them not to biopsy if you think they're going to biopsy. And you will be correct 100% of the time. So aberrant right ICA was the correct answer over here. And this is just to show you that the aberrant right ICA can be associated with a persistent stapedial artery, which sometimes looks like an enlarged tympanic segment of the seventh nerve. And this is the normal side of the cochlea. You can see there should be no soft tissue over the cochlear promontory. And this is the same patient again, showing you the petrous ICA with the ICA sitting over the cochlear promontory. You can see the enhancing ICA on these enhanced images. And this is the jugular bulb over here. So sometimes in middle life or older life, you have the jugulotympanic plate which can be eroded over time, a large jugular bulb which can prolapse into the middle ear, can also look like a retrotympanic vascular mass. And this is what a glomus could look like. You can see that it is an intensely enhancing tumor, has a very different appearance compared to the aberrant ICA that we saw. So we come to case 7. This is a very straightforward slam dunk case. This is the unenhanced CT scan. This is the enhanced CT scan. Okay. This is the unenhanced axial MR. This is the enhanced axial MR. So look at the case again. So CT scans and MRs. Should I go on to the questions? Okay. This is also additional information. Sagittal T2. You can see the lesion over here. And then let's see what the answer is. This is a clue to you. This is an intraoperative photograph of the lesion that I was trying to show you. So the diagnosis, is it vascular malformation, aneurysm, hemangioblastoma, hemangioma, or a pilocytic astrocytoma? Let's go for the, take up your remotes. A, B, C, D, E, press one of them and then press OK after that. 15 seconds, now 13, 11, 10, 9, perfect. 56% of you got the correct answer. So this was a hemangioblastoma. And I just want to show you how vascular a hemangioblastoma is. So one of the clues is if you see any flow voids within a vessel, you see those flow voids over there, and there's a small cystic component. So hemangioblastomas have a classic presentation of an intramural nodule which has a flow void with it, and the nodule is intensely enhancing. So if you looked at this case completely and you also notice the retinal angioma, they call it angioma, but the pathology is exactly like a hemangioblastoma. Your diagnosis is? With a retinal angioma and a hemangioblastoma, the diagnosis is which syndrome? Von Hippel-Lindau syndrome. Right. And you can see this was the pre-op tumor, which looked like a sac of blood vessels pulsating, and this is complete excision in that same case. Okay, now we get to a little more complicated situations. Look at all these diagnoses, memorize them, and I'll ask you questions, right? Very easy to do. I'm just kidding. So this is a list of the common metabolic diseases that we often see. I'll show you 3 cases and you try to match it to this list, okay? So this is the 8th question. There are 3 parts of the 8th question. This is the first part. So this is axial flare images of one of those metabolic diseases. So these are 2 at the level of the ventricle, and this is an axial T2. And then amongst the list, and these are the images that I just showed you, select the best choice. So let's give you a minute to go through this. Is it Canavan's? Is it megalencephalic leukoencephalopathy, Alexander's, metachromatic, adenoleukodystrophy, mucopolysaccharidosis, Halle-Williams parts of Krabbe's disease? So let's go for the answer. Take up your remotes. So you have up to 8 over here, I think. You can press up to 8. Okay, 15 seconds. At least try, give it a shot. It's like gambling. You'll have 20% chance of being correct. And press OK after you press whatever answer you press. So look, most of you got it correct. Fantastic. So this is metachromatic leukodystrophy. Sorry. And if you look at it, this is because the involvement of the white matter anteriorly is equal to the involvement of the posterior white matter. The internal capsule is often spared initially, and the subcortical U fibers, these are the subcortical U fibers, these are spared, they're not involved by this myelinating disease process. So it's a very, very classic case of metachromatic leukodystrophy. So, and if you ever get this in your life, you should be able to make a diagnosis very straightforward. Okay, let's go to the next one. So this is a person who presented with, I think, a large head. These are axial T2s and a contrast-enhanced coronal T1. Mind you, contrast-enhanced, right? So this is the clue, presence with a large head. So again, go to the list and try to come up with a relevant diagnosis over here. So we'll give you 2 seconds to go through the list and then we'll go for the answer, yeah? So what is this condition? Take your remotes and you have 15 seconds to make a choice and then press OK. So 10 more seconds. 3 seconds, 2 seconds, 1 second, done. Okay, let's see. So, well, not bad. Some of you got the answer. That was number 3, Alexander's. And some of you thought of megalencephalic leukoencephalopathy because I said large head. So, this is very straightforward. Again, involvement of the anterior white matter is Alexander's. And these often will present with a large head, and often these are the ones which show enhancement along the anterior margins of the ventricle. You can see the enhancing lesions over here because they incite an inflammatory reaction, Rosenthal fibers, and there's a break in the blood-brain barrier along the lesions anteriorly. So very classic Alexander's disease. If you see this again, you should be able to get it right away. So I'm just showing you very classic cases. We come to the third case in 8C, that is the 8th question that we had. And these are 2 axial flare images. And this is a contrast-enhanced axial T1 image. Now, mind you, I showed you involvement of the white matter anterior equal to posterior. I showed you involvement of the white matter anterior. And this one, I think, is posterior. Maybe you can figure this out. But given this list, make your best diagnosis. So let's go for it again. Take your remotes in your hand. Make a choice. If you don't know, gamble and press OK. And we have 10 more seconds. 8, 7, 6, 5. Okay. And everybody got it correct, I think. 57% of the people got it correct. Fantastic. So the answer is adrenoleukodystrophy. So this is the teaching point, that you have bilateral symmetrical white matter involvement. People will, your pediatrician or metabolic expert will tell you that this is an inherited white matter disease or a neurometabolic disease. And at least these 3 conditions are easy to diagnose. Anterior equal to posterior is metachromatic, more anterior is Alexander's, more posterior is adrenoleukodystrophy. And the clue over here is that this adrenoleukodystrophy is an X-linked disease, so occurs only in males. Very straightforward. Okay, now from amongst this list, we are still not over with the list. Which are the 3 diseases which present with a large head? Now this is difficult to answer, so I'm going to answer it for you. Megalencephalic leukoencephalopathy, Alexander's, and mucopolysaccharidosis are the ones which present with a large head. I think Canavan's also presents with a large head, but I haven't put it in over here. I forgot to do that. And I can see the back row over here nodding in agreement when I said Canavan's. Okay. Last question on this 8th question. I'm sorry, I won't bore you more with this. From this list, choose at least 3 which show enhancement with gadolinium. So again, difficult to answer on the remotes that we have, but I'll answer it for you. So we already saw that Alexander's and adrenoleukodystrophy enhance. A third one, or the 4th one, there are 4 actually, and I said 3 or more. Metachromatic leukodystrophy, people don't know very well that it can enhance, but nerve roots in metachromatic leukodystrophy, particularly in the chorda equina, will show enhancement. And there's a lot of papers coming out on that now. And Krabbe's shows specific optic nerve or optic chiasm involve enhancement if you were to give contrast. So these are the 4 which show enhancement with contrast. Just a trivial facts on these diseases. Okay, we come to case 9. And if you see a posterior fossa midline mass like we do in this case, it could be a medulloblastoma, which is the commonest. It could be a pilocytic astrocytoma, which is the second commonest. It could be an ependymoma, which is much more rare, or a rhabdoid, an atypical teratoid rhabdoid tumor, which is extremely rare. Now, if you look at this case, it looks very much like a medulloblastoma. Sag T1, axial T2, axial flare, sagittal T1 with contrast, axial T1 with contrast. So one of the most important things to do in the medulloblastoma is to go ahead, operate, and completely remove the tumor. If you have completely excised it and there is no tumor seeding along the CSF pathways, the prognosis is very good. The most important factor for prognosis is complete excision of the tumor. So neurosurgeons now really go at these tumors very aggressively. So look at this neurosurgeon, he did a great job. He's completely excised it, even gone up chasing the tumor up to the superior cerebellar peduncles. You can see the superior cerebellar peduncle on the right side, but not on the left side because tumor was extending there and he had to go after it. Okay, now why do you think I'm showing you this case? So following successful gross total resection, GTR as they say in neuro-oncology rounds, this is a 9-month follow-up and this child presented with palatal myoclonus. Now if you look at the images through his medulla, there is a little swelling over here and there's a little enhancement over here. I've magnified these images for you so that people don't get confused. Now having seen that medulloblastoma, having seen the post-surgical changes and having seen this clinical history and these images, what do you think is the most likely diagnosis? Is this, 1 minute. Is this recurrent medulloblastoma? Is it metastatic medulloblastoma? Is it an enhancing infarct? Or is it hypertrophic Olivary degeneration? So let's go for the answer. So A, B, C, D, press the alphabet and press OK after that. And we start now. We have 15 seconds. Do we have 15 seconds? 1 minute. Oh, we got the answer. No, again. Okay, we'll do it again. So go for it again, please. A, B, C, D, and then press OK. Everybody should get the answer on this one. All right. Well, fantastic. I don't need to show you cases because you're getting all the rare cases also. 50% of you got it correctly. And this was hypertrophic Olivary degeneration. Now this is an unusual disease which some people may not have seen, but it's a very specific one. And medulloblastoma is a common tumor which you'll follow up, and once in a while you'll see this, so it's important to remember. What happens is you have this pathway between the inferior Olivary nucleus, the dentate nucleus, and the red nucleus. And the red nucleus, this pathway goes along the superior cerebellar peduncle over here. If you saw that post-operative appearance, the superior cerebellar peduncle had been resected. So that pathway was cut. And this is a paper published by one of my friends, Mayank Goyal. He's an interventional neuroradiologist now at Calgary at the Foothills Hospital. So this is another case. You can see this is the pre-surgery MR, complete resection. And in this case also they had resected the superior cerebellar peduncle. And this is our case which shows you the olive over here. This is the inferior Olivary nucleus. This is the anatomic section. It's swollen and enhancing. And this happens usually 3, 6, 9 months after the surgery. And then if you follow this up, it's a very specific disease which you can diagnose. You don't need biopsy. If you follow this up, like this is a repeat in 2 years, that swelling has gone down, little bit of residual signal in the inferior Olivary nucleus, and the enhancement has completely disappeared. So it is a normal sequelae of brain injury. It's a transsynaptic degenerative process. It causes cell vacuolation initially and then goes on to atrophy. And this is because anywhere if you involve the dentato-rubro-olivary pathway, you can get hypertrophic olivary degeneration. So just remember this. So it's commonly seen in brainstem hemorrhage, ischemic infarction, or iatrogenic involvement of the superior cerebellar peduncle. So don't mistake it for tumor recurrence. And the clinical presentation is classic. It's palatal myoclonus. So points to learn from this is disease at one site can manifest in another site. For example, this is post-surgical changes in the cerebral cortex causing Wallerian degeneration, or an infarct may cause Wallerian degeneration. So remember these things that can occur. Okay, we come to our last case, and then we have a bonus case because I still have time. I have 10 more minutes, right? I have 10 more minutes? Yeah. Okay. So this is a straightforward case, 60-year-old with lung cancer and recent onset of double vision. Just one single image, very straightforward. I thought the last case should not be so long drawn, right? So I'm not going to give you any clues over here. I think you can see it very well. We'll go to the questions and the answers. So look at it again once more. Look at the answers that we have. If you want, I can show it to you again. So what is the most likely diagnosis over here? Is this third nerve involvement with metastatic disease? Is it viral neuritis of the fifth nerve? Is it metastatic involvement of the right sixth nerve? Normal, or is it paraneoplastic disease? So let's go for the questions and answers. Take the remotes in your hand, be ready to press A, B, C, D, E, and then OK after that. Let's go. It's going on. Press it. All right. So the majority got paraneoplastic disease, which it is not. If you go back and look at it, it is actually C, number 3. If you look at this, this is the fifth nerve, and this is the sixth nerve, which is enhancing on the right side. And if you see leptomeningeal enhancement in a setting of cancer, you think of metastatic involvement. So this was metastatic involvement of the sixth nerve on the right side. So just a follow-up question, what is the best MR sequence to evaluate cisternal component of the cranial nerves? Is it a T2 weighted sequence? Is it gadolinium enhanced images? Is it constructive interference in steady state? Some people also call that fiesta. Diffusion tensor imaging or thin high resolution images? What do you think is the answer? Let's go for it. Okay, take the remote in your hand and answer this question. A, B, C, D, E, and OK. All right, most of you got it correct. It is constructive interference in steady state. That is the fiesta sequence. You can get sub-millimeter high resolution images which cause CSF to be bright, so any cisternal component of a nerve can stand out within the bright CSF and you see it very well. Okay, now I want to show you a last case because this is relevant to, well, at least the companion to this will be relevant. I'll show this to you. So 84-year-old male, highly functioning, had some history of diarrhea and then presented with marked cognitive decline. Was treated with a physician before the cognitive decline actually occurred. Oh, I don't know why this came along. Anyway, this is the case. So these are axial T2 images. And if you look at it, the main involvement was of the corpus callosum dorsally and the dentate nuclei. This was some small vessel disease that we'll often see in 80-year-old in the cerebral white matter. But these were the dominant findings, the splenium of the corpus callosum and the dentate nuclei on both sides, and the deep cerebellar white matter was showing these abnormalities. And just to show you, this is what a normal diffusion should look like in these areas. These are normal axial T2 images otherwise, and there was no hemorrhage in this particular patient. And this was very, very typical. This patient was treated for his diarrhea with flagyl or metronidazole, and now these cases are being reported more and more in literature, particularly in older patients who cannot metabolize this very well, or if you have any liver conditions, then you get this specific pattern of toxicity in the brain where you get increased signal in the splenium of the corpus callosum and the deep cerebellar white matter and dentate nuclei. So just to tell you that sometimes in this particular case, it was the radiologist who actually suggested the diagnosis. I went back and asked the history, and the physician was surprised because the doses were normal, but except that the patient was very old and probably had this metronidazole toxicity. The good thing is if you recognize this in time and you withdraw it, they do very well. So flagyl was stopped, and the patient returned to cognitive baseline within several days and was back to normal. So a very important thing to recognize, medications cause a lot of problems in the brain, and these specific patterns are being reported more and more as we do more and more neuroimaging. Now there's a differential diagnosis for this, which is very relevant to Kuwait. I couldn't find a specific case, but the same pattern can happen in hyperthermia. You know, you guys often have very hot temperatures in the desert, 50, 58 degrees, I'm told, sometimes 60 degrees. So when you have severe hyperthermia, you can have very similar pattern of findings, that is abnormality in the splenium of the corpus callosum or the dentate cerebellar white matter, the dentate nucleus of the cerebellar white matter. And it is thought that even the cerebellar surface can be involved because Purkinje cells are known to be especially sensitive to direct heat. So think of these diseases when you see old men on flagyl with cognitive problems or somebody with a heat stroke having a problem. So that was it from me, and thank you very much for all the hospitality and for listening to me.